Your Highness, ladies and gentlemen, welcome to the second Monte Carlo Anti-Aging Conference. It is a great pleasure for me to moderate this exciting event. Last year's Monte Carlo Anti-Aging Conference received much critical acclaim, and I'm confident that this year will be no exception. So without further ado, let us hear some of the breakthrough therapies and protocols from our renowned speakers. Our first gentleman this morning is going to outline the parameters of this conference and the concept of the pillars of aging. As one of the foremost and forthright anti-aging physicians today, he is, I'm sure, already known to many of you, and therefore hardly needs any introduction. So will you please welcome Dr. Ward Dean.
Thanks, Phil, and thank you all for being here. I hope you're looking forward to the next 2 days as I am. Last year's conference, I believe, was one of the most memorable anti-aging life extension conferences that I have ever attended, and I think most of the people who are here will agree. And I think if you look at the schedule of speakers for this meeting, you'll also see that I think this meeting should even exceed what we were able to achieve last year. If we are going to talk about anti-aging medicine, I think the first thing we have to do is to define our terms as to what aging really is, because we have to know what we are against. And this is a standard dictionary definition of aging, that it is the adverse physiological and biomedical changes and the increased likelihood of death associated with the passage of time. And of course, one of the concepts of anti-aging medicine is to consider the aging process itself as a disease. The standard medical model of looking at each individual disease, all the degenerative diseases, trying to achieve life extension or anti-aging improved health only by the elimination of disease, is one that I believe is doomed to failure. Again, a standard dictionary definition of disease is an alteration of a living body that impairs its function. Inherent in the definition of disease are a way of describing the changes that take place with age. When gerontology as a science first began, there was a great deal of discussion about when does aging begin? Does it begin at birth? Does it begin during puberty, during adulthood, or after? And Professor Bernie Strahler from USC described 4 criteria that were inherent in aging-related changes. And it's clear from this definition and these criteria that aging does not begin at birth. Instead, it begins post-adulthood, and we'll go into each of these different criteria. This is that aging changes are universal. They occur in everyone. Unlike diseases, which one person may have arthritis, another person may have coronary artery disease, everyone does not get cancer, but every living organism ages. Second is that it's intrinsic, and I think this is inherent in one of our award recipients this afternoon, and his theory is that aging is a byproduct of normal metabolism. It occurs irregardless of simple lifestyle changes, proper exercise, proper diet, and of course these things can accelerate aging, but aging will occur even without these external influences that may accelerate it. Third is that aging is progressive. It's sort of a one-way street. It doesn't reverse. Now this is one of our goals in anti-aging medicine, is to reverse some of these changes that formerly were believed to be irreversible. And of course, the real reason that we are anti-aging and against aging is because a criteria is that the aging changes are deleterious. They reduce the likelihood of survival, increase the likelihood of disease. This is what happens as we age. Virtually every physiological and biochemical change that is involved in our health and maintaining homeostasis changes in an adverse direction. And the one thing that does not decrease or change adversely is that we unfortunately increase the incidence of just about virtually every disease. Now, this is the typical lifespan curves that we see, and this is what happens due to changes in biomedical science. Rather than extending the curve, all we have done up to now is to square it. The chances of living the maximum lifespan throughout history has not changed. In fact, the chances of living to, say, 75, 85, 90, once a person has reached maturity, have remained virtually unchanged since ancient times. Those of us in anti-aging medicine take a different tack. We look at the aging process itself as a disease, and instead of squaring the curve, which of course is an ideal goal, we want to extend that curve. Extend not only the healthy years of our life, but also to extend the quantity of life itself. I always talk about the aging process as a disease, the one disease that everybody over the age of 35 has caught. And I think this slide illustrates the effect that the aging process, this disease, has on the human body. This is the best recorded age-related times in the New York City Marathon as of a few years ago. I don't doubt if it's really changed very much. And you can see that really past age 30, even though these are probably among the most fit athletes in the world, the times slow as the athletes get older. In fact, and this is a question I often ask, is how many professional athletes do you know who are over 35 years of age? Here at an age when most professionals are just getting started in their careers, and despite probably 20 years of active participation in a sport with the finest coaching, the finest diet, the finest training regimens, by the time an athlete is 35 years old, it's time for him to go out and look for another job. Now, this is Professor Denham Harmon, the creator of the free radical theory of aging, and without Dr. Harmon, we would probably not be here today, because he has been the spark plug for the anti-aging movement. He published his first paper on free radical theory of aging in, I believe it was 1954, and for about 25 years, I don't want to say the theory languished, because certainly it was the topic of much research and much scientific discussion. But really, for about 25 years, about the only place that you read about free radicals and antioxidants was in scientific journals. In fact, Dr. Harmon, in 1970, seeing the shift in gerontological research in the United States, which was begun by the biologists and the physicians, was virtually overtaken by the behavioral scientists, the sociologists, and the people who were really interested in determining better Meals on Wheels programs and what is the optimum distances between bus stops for the elderly. And so that was where the shift in research and money was going. So in 1970, Dr. Harmon formed the American Aging Association, which today is the largest association of scientists and physicians who are dedicated to the biomedical research in aging. In 1980, Dirk Pearson and Sandy Shaw, a couple of hippie-type scientists who were very popular guests on the Merv Griffin TV show, began popularizing and educating the public about Dr. Harmon's ideas. Pearson and Shaw were swamped with mail. The Merv Griffin show received more mail, in fact, from these two guests than from any of their other guests at the time. They published the book, which really started many then students who are now some of the anti-aging physicians and scientists on their path with their book, Life Extension, A Practical Scientific Approach, which made available the research with Dr. Harmon and his associates had been compiling over the previous 25 to 30 years. This book sold over 2.5 million copies and is still available today. About the same time, and this is kind of interesting, is John Mann, who actually lived across the street from Pearson and Shaw and did not know who they were, was working on his own book called Secrets of Life Extension, another book which was, again, focused primarily on the free radical theory of aging, but also addressed a number of other potential anti-aging therapies. This book and Pearson Shaw's book, at the time they came out, were absolutely revolutionary. About the same time that Pearson and Shaw's book came out, I read a book with the mouthful of a title, The Law of Deviation of Homeostasis and Diseases of Aging. It was written by a Russian scientist that I'd never heard of named Vladimir Dillman. And this book was very complex. I had a hard time understanding it, and after reading it about 3 times, I knew that Dillman knew what he was talking about. He really was talking about a whole new concept that I'm going to talk about later this morning. And I began a correspondence with him in 1985, which in 1990 he showed up at my doorstep, and we collaborated on this book that hopefully presented his concepts and theories in more readily understandable language. Yet, even then, it was a highly technical book. Several years ago, Barry Sears, who had also read some of Dillman's work and also the work of Professor Anisimov, who is going to be one of our speakers here, and he tied Dillman's concepts in with his then very popular Zone diet books and created the Anti-Aging Zone concept based on Dillman's concepts. And that is where we came up with the program for this meeting, which is Preventing the Pillars of Aging, which frankly I think it's a lousy analogy, but Phil had already stuck us with the title here, so we were stuck with it. But even though I think the analogy of a pillar of aging is not very good, it does discuss 4 concepts which are key to Dillman's program, because Dillman was not against the free radical theory. It actually, Dillman believed that his theory, the neuroendocrine theory, complemented and supplemented the free radical theory. And these 4 pillars, as Sears called them, are excess free radicals, excess blood glucose, excess cortisol, and excess insulin. And I think that the speakers at this program are going to focus on many of these issues. Now, several years ago, I was asked by the publishers of John Mann's book to revise it and bring it up to date, and I told them, sure, I think I could do that, because my memories of this book were that it was just absolutely revolutionary, and I thought it would only require a few new references and maybe clean it up just a little bit. But when I went back and read this book, I was absolutely overwhelmed, because I was reading ancient history. Because many of the things that we are going to be talking about in this conference were not even dreamed of back in 1980. At least they certainly were not mentioned in the book. And as we continue to get older, and sometimes we start getting frustrated and thinking, boy, this stuff, it's amazing, we're just not making much progress. And it made me feel pretty good, because in rereading this book and trying to update it, which I realized was an impossible task because the book needed to be completely rewritten, is that we have made tremendous strides in the last 20 years. It's based on the foundation established by Dr. Harmon, with a lot of the scientists that were motivated to get into anti-aging based on his work, with his core American Aging Association and the International Aging Association, from which it has spun off. But as I said, this book, Secrets of Life Extension, was now ancient history, and we are going to be talking about, during this conference, many breakthroughs that were not available to us at that time. One thing that many people don't give him credit for is one of his unsung accomplishments, is that in a prior life he was a petroleum chemist with the Shell Oil Company. Through his inventive genius at that time, he provided us with the Shell no-pest strips that are hanging in many people's kitchens to keep the bugs away. I'm sure that Shell Oil made millions off of that, and as an employee, he made nothing off of that. Just another accomplishment. As I mentioned earlier, that I had become acquainted with Professor Dillman's work shortly after graduation from medical school, 1980. and I read Professor Dillman's work. In fact, it's kind of interesting that in the development of the neuroendocrine theory, we have a number of the speakers at this meeting were all referenced. In fact, there are 7 people here whose work has been referenced in support of Dillman's work, including Dr. Harmon, Dr. Walker, Dr. Pierpaoli, Dr. Knoll, and Dr. Bjorksten, and we'll hear more about Dr. Bjorksten's work from his associate, Dr. Kleinsek. Dillman's central thesis, which took me a while before it really sunk in, is that aging is caused by a loss of hypothalamic sensitivity to negative feedback inhibition. This was kind of my first response to this. And so I had to go back and pull out my basic endocrinology books and relearn everything about endocrinology. We all learned in high school that homeostasis is a function of life, that we are homeostatic beings, that it's essential to be in homeostasis. Now, homeostasis just means a very stable, narrow range of optimal conditions for life. Well, Dillman, of course, turned everything upside down and said, well, no, that's not correct. There's actually a progressive shifting of homeostasis throughout life, because if we were truly homeostatic beings, we would never grow, we would never develop. And he knew that there was a central regulator someplace in the body, and this is, now we talk about receptor upregulation and receptor downregulation. He figured this out even before anyone knew there were receptors, because the endocrine system is sort of a classic cybernetic system with feedback through various levels, and we'll be talking about this more. That I guess the best example of a homeostatic system is the thermostat that maintains this auditorium in a fairly comfortable environment. When it gets too warm, the air conditioner kicks in. If it got too cold, the air conditioning would turn off and the heat would come on. And this is basically the concept of homeostasis. But as Dillman pointed out, if we were homeostatic, we would never develop. He also knew that there were living organisms have 4 capabilities. They reproduce, they adapt to the changing environment, they process and produce energy, and they protect themselves. And so he theorized 4 separate, what he called homeostats: a reproductive, adaptive, an energy, and an immune homeostat. And I'll talk you through each one of these just to understand his basic concepts. This is the reproductive homeostat. The central part of this is, as Dillman theorized, was the hypothalamus, the central organ in the brain. As we're going to learn later from Dr. Pierpaoli, that probably there's an even higher controlling factor, and that's the pineal gland. There are releasing factors that stimulate the pituitary, that then produce tropic hormones FSH and LH, which then stimulate the testes in men and the ovaries in women to produce estrogen, testosterone, and progesterone. Now, if we were homeostatic beings, the small amounts of estrogen and progesterone that are produced even in infants would be adequate to, through feedback inhibition, to shut down the hypothalamus and the pituitary, so that we would always only have these small, relatively insignificant amounts of estrogen. And Dillman theorized that the only way that the higher amounts of estrogen and the higher amounts of testosterone that are necessary to trigger the maturation of the reproductive axis would be through a loss of sensitivity of the hypothalamus to negative feedback inhibition. And so pretty soon this stuff kind of starts rolling off your tongue. And in fact, this is what happens as we age. FSH and LH progressively increase, resulting in increase in estrogen, until at some point, as Dr. Lee was talking about, during menopause, even extremely high amounts of FSH and LH fail to cause the ovaries to produce any more estrogen. In fact, the ovaries are almost, it's like a suicide mechanism, because not only have they been pummeled for 20 to 30 years by these fairly high amounts of FSH and LH, but also the estrogen itself is probably toxic to the ovaries, which results in basically a shutdown of estrogen. And we'll see that that may not be such a bad thing, because also as the estrogen plummets, at this point there is virtually no output of progesterone. And so even as a woman ages, she begins to become more and more estrogen dominant. Postmenopausally, it becomes almost entirely estrogenic, and so then we are subject to the toxic effects of the estrogens. Similar changes occur in men. The change is just not quite so dramatic. There's a progressive rise in FSH and LH, beating up on the testicles until at some point they fail. And also, you notice that the estrogen continues to rise. And this is due to very efficient and increased amount of an enzyme called aromatase, which helps to convert the testosterone that is produced into estrogen. And that causes this progressive increase in estrogen in men. In the adaptive homeostat, we see a similar occurrence. We've got the hypothalamus. We have that producing corticotropin-releasing hormone, which stimulates the anterior pituitary to produce ACTH, which causes the adrenal cortex to produce cortisol. Now, cortisol is the body's primary adaptive hormone. It's produced in high amounts during stress, and we need cortisol. Without the cortisol, we, of course, could not survive. But cortisol, like estrogen and insulin, is an essential toxin. And so we need it, but we need it in small amounts. High amounts over a prolonged period of time have very damaging effects. And Dillman showed that time and aging is a natural stressor. And this is a study that he did where he shows for women who are being operated upon for breast cancer, and that the younger group, under 46, had a lower cortisol response to the surgical stress and a more rapid return to baseline. But as age increased, we see a progressively higher and higher output of cortisol with its attendant damaging effects. This is, in fact, Dillman created a disease which he called hyperadaptosis. And hyperadaptosis is the result of a body's prolonged exposure to cortisol. This results in many of the symptoms similar to Cushing's disease, such as the moon face, the red cheeks, the central obesity, thin skin, easy bruisability, sort of bulging abdomen, poor wound healing, poor muscle development. These are all characteristics of excess exposure to cortisol. And in fact, these are some of the known effects of hyperadrenocorticism, which is immunosuppression, osteoporosis, atherosclerosis, diabetes, impaired blood sugar regulation, and it actually kills brain cells. So these are all effects of chronic stress, and Dillman believes that everybody suffers to a greater or lesser degree from hyperadaptosis. And we've heard Dr. Harmon already talk about this, is the mitochondria, which is also a key to both theories, to both the neuroendocrine and to the free radical theory of aging. This is basic with the thyroid. This is the typical, again, cybernetic system with the hypothalamus producing TRH, and we're going to hear more about the importance of TRH from Dr. Pierpaoli, stimulating the anterior pituitary to release TSH, thyroid stimulating hormone, which triggers the thyroid to produce T3 and T4. And this is sort of a well-known change with aging in our energy metabolism. Anybody that has children, we know that they're just bundles of energy, and as people get older, the levels of fatigue increase, energy reduces, and this has been demonstrated time and time again in studies of basal metabolic rate as the basal metabolic rate decreases with aging. Now, this is Dillman's concept of the change in the growth hormone insulin energy homeostat, where you basically have reciprocal relationships with the growth hormone, free fatty acids, glucose, and insulin. And when growth hormone is produced in adequate amounts, and when the body is responding appropriately to insulin and utilizing glucose appropriately, and using, again, free fatty acids for energy, everything stays in balance. However, after about age 30, when our requirements for growth cease, our output of growth hormone also basically becomes negligible. And we're going to hear more about this from Dr. Walker later on. But unfortunately, without the growth hormone input, this aspect of the energy homeostat, Dillman used to call it a headless homeostat, because the effective growth hormone was lost. We're now suffering from insulin resistance. The level of free fatty acids in the blood and glucose both rise, resulting in hyperglycemia, hypertriglyceridemia, and a number of the other metabolic consequences of aging. This shows the change in glucose tolerance with age, partially as a result of this and due to insulin resistance. And this shows the results of a glucose tolerance test on the insulin response as it changes with age. And you can see from this that children 4 to 10 years, very finely tuned energy homeostat, in that there's a slight bump in sugar in the insulin, rapidly returning to normal. And with age, we get a progressively higher and more prolonged insulin response until finally, in the advanced years, insulin just stays up and resulting in hyperinsulinemia. Now, Dillman was proposing this back in the late 60s, early 70s, talking about the hyperinsulinemia of aging. And he was roundly criticized for this. In fact, no lesser person than Dr. Nathan Schock wrote several paragraphs about this erroneous concept that Dillman had, the ridiculous idea that older people suffered from hyperinsulinemia because everybody knows that glucose tolerance decreases with age, and obviously there's less insulin. And so today, however, all we hear is Syndrome X and the problems with hyperinsulinemia. But I challenge you, in any of these articles that you read in any of the major medical journals, to find any reference to Vladimir Dillman and his prophetic concepts way back in the early 70s. The third aspect of the energy homeostat is the mitochondria, and as Dr. Harmon pointed out, this is a real point of interaction between the free radical theory and the neuroendocrine theory, because of course the mitochondria are the key to the body's energy production. And of course we've all seen the Krebs cycle, we've learned it and forgotten it many times, but this is really the key to the mitochondria. If we can manage to keep our Krebs cycles functioning, generating ATP, which is the body's universal energy molecule, we may be able to keep these mitochondria functioning at a much more youthful level. Fourth is the immune homeostat. Again, as Dr. Harmon pointed out, the immune theory of aging was one that was proposed by Dr. Roy Walford, where he had a very similar cascade of diseases which he attributed strictly to a breakdown in the immune homeostat. And you can see here the complex interactions between the thymus and the rest of the endocrine system. And this was a little bit of a complex chart, but I'll talk you through it. This shows the changes with age of the thymus. With age, the thymus begins to atrophy. The active portion, the cortex, is replaced with connective tissue and fat. The amount of thymic factors in the blood decreases with age, and it was theorized to result in the diseases of aging. So these are the four homeostats that Dillman predicted and theorized that in combination resulted in the diseases of aging and aging. And he showed what he believes is just a typical metabolic pattern of aging. Includes insulin insensitivity, hyperinsulinemia, glucose intolerance, obesity, increased utilization of free fatty acids, hypercortisolemia we talked about, decreased output of sex hormones, decreased immunity, increased autoantibodies, increased gonadotropins, hypertension, and hypothyroidism. This is basically the same pattern that you can find in almost all of the chronic degenerative diseases. It's just how is it manifest, it's sort of which is the weakest link in the chain. And we saw the diseases of aging that were attributed to the free radical theory, the autoimmune theory, the immune theory of aging attributed a series of similar diseases. Dillman proposed that these were the primary diseases due to the neuroendocrine theory, and we're going to hear later from Dr. Kleinseck about the cross-linking theory, where a very similar array of diseases are attributed to cross-linking. So all of these theories, they are not mutually exclusive. I think it shows that there is no magic bullet. There's no single substance that is going to reverse all of these changes. But I think by the use of antioxidants, substances that I'm going to talk about, and the anti-aging approach that Dillman suggested, the cross-linkage inhibitors that Dr. Kariasis is going to talk about and Dr. Kleinsecker are going to talk about, and I think that by a combined approach, we can truly retard the aging process and perhaps increase the maximum lifespan. In fact, this was in Business Week several years ago when even businesses are now realizing, gee, this is, there may really be something to this, and there also may be some business to be made here. Now, this was the approach that Dillman suggested to fight aging based on the neuroendocrine theory. First, and I think this is absolutely unique in his theory, is to restore hypothalamic and peripheral receptor sensitivity. And I think this is probably one of the most fruitful areas of research there is. And the things that I'm going to talk about, there's a lot of stuff, it's just, personally, it's my ideas, it's based on Dillman's work and on recent research, and we're going to hear more about it from some of the other speakers. Second is to replace hormonal deficiencies that may develop. Third is to prevent adverse hormonal effects, primarily from cortisol, insulin, and occasionally from estrogen. And finally, to optimize intracellular bioenergetics. And these are some of the therapeutic regimens that Dillman recommended, or that have been developed since then. First is to restore hypothalamic and peripheral receptor sensitivity. Dillman did a study. This is metforol. It's an Italian version of a drug that was recently introduced in the United States, metformin. Metformin is an anti-diabetic biguanide which restores insulin sensitivity. It's completely different from the other oral anti-diabetic drugs. I still find patients that are taking diabinase and glucotrol and things like that. As far as I'm concerned, that's kind of like taking the pancreas out, putting it on the kitchen table and going over it with a rolling pin just to squeeze out more insulin in a person who is already insulin resistant. And Dillman foresaw this and recommended this class of drugs. The one that he used was an old drug known as fenformin. Fenformin was taken off the market in 1976 due to a number of excess deaths due to lactic acidosis, and it was deemed to be a dangerous drug, and so it was taken off the market. But if you talk to any of the old-time diabetologists that used to use fenformin, they'd say, oh, gee, this was a wonderful drug. It lowered cholesterol and triglycerides, stimulated the release of growth hormone, the patients lost body fat when they took it, alleviated their hunger pangs. It's just a wonderful drug. And what happened was that people were using it indiscriminately in very brittle, severe diabetics who invariably would get kidney dysfunction, and with impaired kidney function, unfortunately, lactic acid could build up, and that was what resulted in the excess deaths. The likelihood of lactic acidosis with metformin is even less than with fenformin. I think it's about 0.03%. And again, this is really in diabetics and severe diabetics. So it's fairly easy to use this substance and very safe to use this substance in patients who have normal kidney and liver function. This is a study that Dillman did, I think it was 1976 or so, with Professor Anisimov, where they used fenformin and they extended the maximum lifespan of mice and rats using this substance, and they also reduced the incidence of tumors. Dillman was an oncologist, so he was very much interested in, of course, cancer prevention, and an integral part of all of his anti-cancer treatments was the use of fenformin. And he stated in his book, The Law of Deviation of Homeostasis and Diseases of Aging, that he believed that fenformin was the best anti-aging drug there is. I believe that metformin is the best anti-aging drug there is, basically because it keeps insulin low. But it also has this other wide-ranging breadth of beneficial effects. It keeps cortisol levels down. It restores hypothalamic sensitivity to cortisol. If the kidneys are functioning, it's very safe. I think it can be taken like a vitamin. I put all my patients over 35 on metformin. The only adverse effect I've had was in one patient who had a little gastrointestinal intolerance to this stuff, but she got gastrointestinal intolerance to everything. Another drug that restores hypothalamic sensitivity, I think very underused, is Dilantin. Dilantin, of course, is an anti-epileptic drug that in clinical studies has shown some effects very similar to the biguanides. This is a insulin, again measuring insulin during a glucose tolerance test, and this was before Dilantin was administered. You see these big spikes in insulin. This is the insulin curve during a glucose tolerance test in the same people after taking Dilantin. Dilantin is known to be one of the few drugs that will boost HDLs, and of course that's a problem trying to raise HDLs. I think that one of the reasons that HDLs go up is when insulin goes up. So the key is keep your insulin down, and that will result in the HDLs going up. And I believe also, Professor Nisimov can correct me if I'm wrong, but the Dilantin was also used in lifespan studies, and I believe that also resulted in extension of the lifespan. Dr. Harmon talked about the benefits of caloric restriction, and certainly caloric restriction is the best tested way to extend the maximum lifespan in experimental animals. The thing is, people don't live in cages. You can't keep humans chronically hungry the way you can keep these experimental animals hungry. I think that the mechanism by which caloric restriction works is because when the animals don't eat, they don't get an insulin response, and the insulin stays low. Many of the benefits of caloric restriction can be obtained by drugs, metformin, fenformin, and perhaps Dilantin, to keep the insulin levels low. I use these on hypoglycemics as well as on diabetics. It relieves hunger pangs in patients who are hypoglycemic, and they're not running around looking for candy bars and Cokes in between work, because it just maintains such stable levels of blood sugar and insulin. Now, of course, one of the big questions that I had was, what causes the receptor downregulation in the hypothalamus? Well, one of the causes, of course, is just being pummeled by higher and higher levels of these hormones. Second is, and this was one of the main causes in Dillman's mind, was that it was caused by a decrease and an alteration in the balance of the catecholamines and serotonin. He also believed that another cause of loss of receptor sensitivity was due to free radical damage in the hypothalamus. So here again was another link between the neuroendocrine and the free radical theories. So one of the first anti-aging drugs, in fact I think it was the first anti-aging drug that was ever presented at a scientific meeting, was Girovatol, or GH3. In fact, we have the designers of Girovatol's personal physician, Dr. Mercy Dumitru, who spoke last year. He's here in our audience today. And the mechanism of action of Girovatol was believed to be that it was a weak reversible monoamine oxidase inhibitor. And by inhibiting monoamine oxidase, you would maintain higher levels of the catecholamines. Although there are no lifespan studies that I'm aware of using Girovatol, a derivative of Girovatol, DMAE, dimethylaminoethanol, was tested by Hochschild, and that did result in extension of maximum lifespan of experimental animals. It may have been due to the membrane stabilizing effects of the DMAE, as Hochschild hypothesized, but it may also have been due to the increase in acetylcholine and possibly to the increase in the catecholamines due to DMAE. More recently, a substance that was developed by Professor Knoll, and we heard him discuss this last year, was Depronil. Depronil was originally believed to be, and it may be, a reversible inhibitor of monoamine oxidase, a very selective inhibitor of monoamine oxidase B, used primarily for Parkinson's disease, but it's also been used for a wide variety of other aging-related illnesses, specifically Alzheimer's disease, and just as an aphrodisiac Professor Knoll demonstrated the benefits of Deprenyl as an aphrodisiac in experimental animals, and from anecdotal reports from many patients, they've reported the same findings. And significantly, Deprenyl is one of the substances that, again, has extended the maximum lifespan of experimental animals. This is a study that Professor Knoll did, but there are also further studies by other researchers with other species that reported similar results. And Professor Knoll handed me a paper yesterday and said, "Here, I think you might be interested in this." And it was a new drug that he's developing that increases both hypothalamic sensitivity to the catecholamines and to serotonin. So this may be, with further research, we may find that this may be the answer to reverse that abnormal balance and the decrease in the catecholamines and in serotonin with age. I believe that references will be out there with the exhibits. So as I said, I think this is a really major area for future research, is to identify and develop other more efficient, more and particular specific hypothalamic resensitizers. And these are some that I have found either just because I think they probably are, for example, with calcium aminoethanolamine phosphate, and with some of these others I'll go through very briefly. Aminoguanidine is a derivative of guanidine. Guanidine, of course, is the original molecule from which the anti-diabetic biguanides were developed. Aminoguanidine has been shown to both lower blood sugar, to inhibit cross-linking, and Professor Nisimov told me last night that he's also found that it is anti-mutagenic. I'm not surprised, again, because Dillman used to use fenformin as an integral part of his anti-cancer programs. DHEA restores hypothalamic sensitivity to insulin. Forskolin is a stimulator of adenylate cyclase. Adenylate cyclase is an enzyme that is involved in the membrane. It's a second messenger that helps the hormones do what they're supposed to do. SAMe, adenosylmethionine, is specifically a prolactin receptor sensitizer, and we're probably going to be hearing more about that from Dr. Brown. Adaptogens, Eleutherococcus, the Siberian ginseng, Rhodiola rosea. Those are, I'm not sure if Dr. Brown's going to talk about those. I hope we can get him to do that, because those are also hypothalamic resensitizers. Tribulus, Vitex, and black cohosh are all, I believe, specific receptor sensitizers for the sex hormones. So I think that by the use of Tribulus, which has been primarily used in men, and the Vitex, which has been primarily used in women, both of these substances normalize the LH-FSH ratios, and although they have no hormonal effect of their own, the hormones actually work better, and it reduces the adverse side effects from the hormones. Various neuropeptides, vasopressin, which is available as a nasal spray. It's posterior pituitary extract, which has been synthesized. This is what blocks formation of urine. When I was an Army and Navy flight surgeon, I used to prescribe this to the pilots because they'd get on a 2 or 3 hour flight, and it's kind of uncomfortable and messy to have to use this relief tube in the aircraft. And so I'd pass this out to the pilots and have them take a few sprays and help them to complete the flight without having to go to the bathroom. It's used now in many children who suffer from bedwetting. I think it helps men with prostate problems because they don't have to get up in the middle of the night to urinate. It actually rejuvenates intracellular water balance. One of the characteristics of aging is dehydration, and by the use of vasopressin, it's been demonstrated in clinical studies to actually help to maintain hydration of the cells. A recent study also showed that it improves slow wave sleep. This is the time of night during sleep when growth hormone is produced. I haven't seen any studies that show the growth hormone releasing effects of vasopressin, but I wouldn't be surprised. We discussed it in my smart drug books because it is one of the best means of improving short-term memory and recall, And there's a study that was done in 1976 using a posterior pituitary extract in rats that it was started in elderly rats. Active ingredient, of course, was the vasopressin, and it reduced the mortality rate of these older rats. We'll also be hearing some more about TRH from Dr. Pierpaoli. Gamma oryzanol, I believe, is a receptor sensitizer for growth hormone. It's used as a growth hormone agonist in veterinary medicine for cattle to reduce body fat, maintain lean body mass. Acetyl L-carnitine, which is a receptor sensitizer for cortisol, and phosphatidylserine also, which restores receptor sensitivity to cortisol and reduces the damaging effects of cortisol. And the other thing that I forgot to mention is blueberries, because recent research came out on the receptor sensitizing effects of blueberries. Second is to replace hormonal deficiencies when they occur. I think a popular book by another one of my anti-aging medicine mentors, Dr. Bill Riegelson. This was a comprehensive regimen for hormone replacement therapy, absolutely revolutionary when it came out. And this is, most of the regimens in here can be use various dietary supplements, but also he did recommend the use of a number of prescription hormones. I talked about the little higher aspect. This is the melatonin miracle. Basically, Dr. Pierpaoli is one of the top two research scientists in my mind in the world in the use of melatonin as an anti-aging substance. Melatonin, of course, is produced by the pineal. This slide illustrates the changes that take place in melatonin with age. Young people have a very pronounced spike in melatonin release, peaks about 1 or 2 o'clock in the morning, drops dramatically thereafter. Older people, the rise is much less dramatic. It peaks later in the night and again drops off. And of course, anybody who has been around a number of elderly patients in the hospital, one of the biggest problems we know is they can't sleep at night. And when you can't sleep at night, you're tired during the day, you become confused, fatigued, forgetful, constipated, and many of these, what we consider age-related changes, can be reversed just by making sure that people get a good night's sleep. And for those of us that made a long trip, we know that melatonin will dramatically reduce the symptoms of jet lag. This was a study that was done on a number of patients that made a San Francisco to London flight. This is the group that was taking placebo, and this was their complaint scale based on the severity of jet lag symptoms. This group did not take melatonin. This group was the melatonin group. Obviously a much dramatic subjective symptom sensation. I recommend 1 milligram per time zone crossed in addition to whatever a person may have been taking as a baseline. I found that there is a very small percentage of people who can't take melatonin. They get an idiosyncratic reaction. It causes them to, get a little hyper. But for most people, it's extremely safe. It's been used in very high doses. I'm sure Dr. Pierpaoli is going to give us more information on that. And this is one of Dr. Pierpaoli's studies, which showed, again, that melatonin will extend the maximum lifespan of experimental animals. Now, going a little bit beyond the use of melatonin, another pineal extract, and we're going to hear more about this, is this was done by Dillman and Anisimov, where they used a melatonin-free pineal extract, which again resulted in extension of maximum lifespan and a reduction in tumor incidence in experimental animals. Another physician who was a real pioneer back in the 40s, Broda Barnes, did studies of basal metabolic rate and thyroid function in patients, and he stated that, and I think he was being very conservative in this, that 40% of the adult population is functionally hypothyroid. Of course, physicians today were very sophisticated, and we monitor the TSH levels, and the goal is to use Synthroid and to maintain TSH levels in a very narrow range. And as long as the blood test is within that narrow range, they think the patient is doing fine, and even though they still come in and their hands are cold and they wear socks to bed at night and they're fatigued and depressed and can't seem to lose weight, as long as that TSH is in the normal range, they send them out of the office and oftentimes off to the psychiatrist, when perhaps, as Dr. Lee said, a little bit of progesterone would solve the problem, or perhaps using thyroid, and I preferentially use the natural desiccated form of thyroid, either thyroid USP or Armour Thyroid, or Biotech is another company in the United States that has a natural form of thyroid. They use the same as the Armour Thyroid, but it does not have the cornstarch, to which a lot of people are allergic. We'll hear more, as I said, about growth hormone from Dr. Walker. This was a book by Dr. Klatz that really popularized the use of growth hormone. And growth hormone, of course, is no longer derived from bovine pituitaries. It's now synthesized, and the price is coming down to where it's fairly reasonable in price. I don't think that there is any standardized optimum protocol for the use of growth hormone. Many physicians monitor IGF-1 levels, and they want to keep it in some magic range of 300 to 500. Others use 1 unit 4 days a week and off for 3. I know of a couple of physicians that recommend its use intravenously in doses as high as 5 units once or twice a week. Protocols are just all over the place. I'm hoping Dr. Walker will clarify this and provide a little more data on it. Finally, another hormone that we don't really think about very much, but this ties in basically with the immune homeostat and with Dr. Walford's immune theory of aging, is to replace these thymic hormones, which are deficient as we get older. There are several preparations that are out there widely available. One is thymic protein A, sublingual powder, and there's also a European version, which is a slightly different group of peptides, Thymuvocal, which is both oral and I believe there's an injectable form. Am I not correct? And this was an interesting paper that I just ran across. In fact, it came out in Dr. Harmon's organization's journal, Age, where it pointed out that the insulin receptors in mouse brain can be resensitized by using thymic extract. And again, this shows the sophisticated interplay between the entire neuroendocrine system, and I think the importance of trying to identify substances that will act as receptor sensitizers. You saw a version of this in Dr. Lee's talk, where he was talking about the hormone cascade, which we've all seen, where it starts at the top with cholesterol, which is converted to pregnenolone, which is the real mother hormone, which pregnenolone will go down either the progesterone pathway or the DHEA pathway to androstenedione, estriol, and testosterone, and the other androgens. Now, many people have said, well, gee, if I'm taking pregnenolone, do I need to take DHEA? Or if I'm taking pregnenolone, do I need to take progesterone? Because it converts that way. Well, of course, the problem is not often lack of the precursor, but it's the problem with the enzyme systems that cause these conversions. Because if the solution was just to take the precursor, well, then all we need to do is just load up on cholesterol and everything would be fine. We obviously know that although cholesterol is not the enemy that the food processors would like us to believe, I think the oxidized cholesterol is dangerous. Unoxidized cholesterol that you find in runny egg yolks, I think, is highly beneficial. This much published slide that shows the dramatic drop in DHEA with age in both men and women. Dr. Eugene Roberts from City of Hope in Duarte, who was one of the early researchers with pregnenolone back in the 40s, said that he thinks that, and I haven't really seen any papers on this, but he said that the drop in pregnenolone is probably as dramatic as the drop in DHEA. In fact, he was doing his initial research back in the late 40s. It was published in the New England Journal and major journals, and it was primarily used as an anti-inflammatory neurosteroid. And he said, while he was in the lab, and one of the company presidents came through and wanted to see what he was working on, and he starts waxing eloquently about this. And they said, well, look, you know, we've got prednisone now and prednisolone and these synthetics, so just forget about that. And so he stuck it in the drawer and forgot about it until he got into his 70s, and he started getting little joint pains and kind of creaky and becoming a little forgetful. And he remembered his mouse studies with induced arthritis, and where he was showing that with pregnenolone, The experimental animals were improving in cognitive performance. It was a powerful anti-inflammatory without the damaging effects of cortisol. And this illustrates some of the benefits that have been reported with pregnenolone, that it is a cognitive enhancer, improves memory. It is an antidepressant in many cases and a powerful anti-inflammatory without the adverse effects of cortisol. DHEA in France here is really big news now. It's kind of old stuff to folks from the United States because we've had it out for a few years. It was big when it broke there, but it was considered Class 1, Schedule 1 anabolic steroid, or the equivalent in France. It was an illegal drug. Well, it's just been recognized as a drug. It is available now by prescription in France, and so all the newspapers now they've sort of gone through and dredged up all the old newspaper stories that appeared in the United States about the potential dangers and hazards and everything, and so until the establishment blesses it in France, it will probably still remain somewhat controversial. But again, DHEA has been reported to result in a wide range of beneficial effects. I think it restores insulin sensitivity, it restores immunity. Most of the experimental animals studies that have used it as a test of immunity have shown that it will boost immunity. There are no studies that I know of that show that it extends maximum lifespan, but it does normalize many of these aging-related parameters that change adversely. Third is to prevent adverse hormonal effects. Primarily, we're looking at the adverse effects of cortisol, insulin, and in some cases estrogen. With estrogen, because, and this is principally in men because of their very efficient conversion of testosterone to estrogen, there are a couple of, basically 3 approaches to use. One is to use Arimidex. This is a drug in doses of anywhere from 1/4 to 1/2 to up to maybe 1 milligram per week. Very powerful, also very expensive aromatase inhibitor, but it very specifically blocks the conversion of testosterone to estrogen. Second is the use of indole 3-carbinol or diindolylmethane, both of which enhance estrogen metabolism, act almost like an estrogen vacuum cleaner, just sort of sucking up the excess estrogen. I know some women who have used this, and in fact it was so effective it gave them hot flashes because it just eliminated the estrogen so dramatically. And third, and this is a little bit of a question here, is the use of an herb chrysin as an aromatase inhibitor. Jonathan Wright, I know, very strongly believes in this, but there's very little published data to substantiate its use for this purpose. We talked also about the ways to prevent the damaging effects of insulin, using the biguanides, using dilantin, also exercise, DHEA. And finally, we want to restore intracellular bioenergetics. And I think this is, again, a real challenge where we're trying to look at what is an optimum regimen to keep those mitochondria functioning. Now, one of the other characteristics of mitochondria with age is that if you take a young athlete and you put him on a training program, the mitochondria replicate like crazy to ultimately result in increased energy production. With an older person, the mitochondria replicate less readily, they just become larger, so you have these larger, somewhat less efficient mitochondria. So this remains a real challenge in the energy production. Again, it all focuses on the Krebs cycle. A number of approaches have been used to enhance the efficiency of the Krebs cycle. One is to use CoQ10, and in fact, in a lifespan study of old mice that were given, these are already old mice, that were then begun on a regimen of CoQ10, and the mortality rate of the mice dropped dramatically, where the controls just continued to die at their regular rate. I've seen one study that showed that CoQ10 may extend the maximum lifespan. I've seen another study that showed that it had absolutely no effect. But in view of the wide-ranging effects of CoQ10, I strongly recommend that. NADH is an interesting coenzyme. It was developed by George Berkmeyer, who was the discoverer of and patent holder on L-DOPA for Parkinson's disease. And NADH is, in fact, another substance that is used in Parkinson's disease. Many people with chronic fatigue have used it and found that it greatly enhanced their energy. Carnitine, dietary supplement, it's also acetyl L-carnitine, has been used. This shows the effects of carnitine on cellular membranes and on the effect of cardiolipin. Cardiolipin is integrally involved in the energy-producing efficiency of the mitochondria. In young folks, it even increased the cardiolipin levels in young mice. With age, cardiolipin drops dramatically, but in the aged, it dramatically and completely restored cardiolipin levels to those of youth. Dr. Lee talked briefly about the effects of exercise, both as a stress reliever and for its many other beneficial effects. It's kind of a two-edged sword because there's now stuff coming out that shows that exercise can also raise cortisol. So I think that exercise is very important. I've already said that it's one of the best anti-aging pills there is, but I think that it needs to be just slightly below the level where it causes inducible stress. Another anti-aging technique that I think is not talked about enough is getting adequate sleep. This is a book that came out last year where it really is applied Dillman, and they addressed all of these pillars that we're talking about: the excess cortisol, the excess free radicals, the excess glucose, and the excess insulin, and they attributed it almost entirely to the lack of adequate sleep and to the electrification of the world. And they showed that as the world became electrified and people started staying up later and getting less and less sleep, that all these diseases began. And although I don't think that, obviously, that's not the total answer, I think it's a big answer, and I think that many people suffer from chronic sleep deprivation. You know, the kids stay up at night watching TV, doing whatever they're doing, then they've got to bounce out of bed at 6 o'clock to get off to school, and they go through life just in a chronic state of sleep deprivation. I think this is a really dramatic book, and I would recommend it to anybody, although I don't agree with everything. They poo-poo melatonin, they poo-poo just about everything else. But what's really interesting is in the dedications, they dedicated the book to Dr. Eve Van Cotter from the University of Chicago. Well, Dr. Eve Van Cotter is one of the major studies in the sleep-producing effects of GHB, which I talked about last year. And so I will just leave this last slide as my last recommended anti-aging substance, because GHB is the one substance that will produce natural sleep. All the other pharmaceutical sleep-inducing agents, although they will knock people unconscious, they do not result in natural sleep. I think the judicious use of GHB or its precursors, and there are three known: butanediol, butyrolactone, and velolactone, all are converted 100% into GHB in the body. GHB is metabolized into carbon dioxide and water. There are no toxic metabolites, and it's been used in a wide range of diseases. So in sum, I would like to, again, pay homage to Professor Dillman, who I consider my mentor. Phil, if I got a minute or two left, I appreciated Dr. Harmon going into a little bit of his history, how he got where he was. I'd been corresponding with Dillman from about 1985 to about 1990. And in 1990, I joined the Navy as a flight surgeon. I spent 6 years in the Navy. And at that time, I'd been corresponding with him prior to that time, and just after I joined the Navy, he showed up on my doorstep. So I dutifully, because I had a contact with somebody in a communist country, reported to the intelligence folks, and I was paid a visit by an FBI agent who came over. This guy was nearing retirement, and he was very interested in the smart drug books and in the book that Professor Dillman and I were writing. And so he was very cordial, and he left. And so just recently, about 6 months ago, I thought, well, let me check and see if anything ever came of this. So I submitted to the FBI a Freedom of Information Act request for my FBI file. And I waited and waited and got nothing, so I sent another certified letter and finally got a response that yes, they did have a file on me, but it would take some time for them to produce it. And I waited and waited and waited, and I kept calling, and they said, well, we've got something, but it's not much. And so I got my congressman the act, and I said, hey, you know, the FBI is not coming through with my file. So then I got a call from this attorney from the FBI, and he said, well, yeah, we do in fact have a file, and we'll, because your congressman's interest, we'll send it off to you. They said, unfortunately, you're not going to be able to learn much from it because it's all top secret. So I'm still waiting on that file, and as soon as I get back, I'm going to write my congressman another letter and tell him the FBI is not complying. But my curiosity is really aroused as to what is in that file. But I thought it was very funny because it's just a strictly scientific endeavor, and the Cold War at that time was supposedly over, but it's still buried in the bowels of the government. So one more thing, Dr. Roy Walford is the only, as we said, caloric restriction is the best known way to extend the maximum lifespan, but very few people follow it, and Dr. Walford is really the only person I know who follows it dutifully, and people have said, well, Roy may not live any longer, but it'll sure seem like it.
One of the primary concerns we all have with aging is a progressive loss of cognitive functions through what is termed as age-related mental decline. Giving his final lecture at this conference, would you please welcome again Dr. Ward Dean.
Thank you, Phil, and I hope everyone is enjoying this conference as much as I am. When I first started practicing anti-aging medicine back in the mid-'80s, one of the first things that many of my patients would come in and ask is, what can I do about improving my memory, improving my cognitive abilities? This was a very select group because most of these patients had already managed to get through the 800-plus extremely well-referenced magnum opus by Dirk Pearson and Sandy Shaw. So this was a pretty smart group of folks. But they were in their middle to beginning to be in their anywhere from 35, 40, 45. And they were people who depended for their livelihood on their cognitive abilities. They were accountants, CPAs, attorneys, physicians, computer programmers, and just a lot of bright folks. But they knew they would see these hungry kids coming out of college. Their cognitive abilities were really what put their jobs in jeopardy. So I realized this was really an area of very great importance to anti-aging life extension enthusiasts. It doesn't do any good to have an 85-year-old brain in a 35-year-old body. So I wrote the first book, Smart Drugs and Nutrients, basically so that I wouldn't have to keep repeating myself to all my patients and keep saying the same things over and over. It was just kind of a working in-house manual. My co-author, John Morgenthaler, in fact, was one of my patients. So he took the book once it came out, and the way it really got started was that he called the FDA and said, what do you think about these new smart drugs? And they said, we think these are really stupid. And so, of course, John put out a press release. FDA says smart drugs are stupid. Went out to about 1,500 newspapers around the country, and of course sales took off like crazy. And as sales peaked, started dropping off, John next called the Educational Testing Service that provides all of the testing for entrance examinations into colleges and universities, and said, do you think that it's ethical as for people taking these tests to take smart drugs? Oh, no, terribly unethical. And so, of course, the next day there was this press release that went out about how the Educational Testing Service says that taking cognitive enhancing drugs before these tests is unethical. And sales took off again, and that resulted in the second book. But basically, before I get started on this, we've had a lot of requests for information about the book which I co-authored with Professor Dillman, The Neuroendocrine Theory of Aging, as to its availability. Unfortunately, when we published this book, we believed that it was a very technical book, and usually publishers of books in this particular area put out anywhere from 500 to 1,000 copies. So we courageously printed up 1,500, and they were out of print within a year. But we are revising it, and we do at VRP have a series of chapters that have appeared in our newsletter, which we are going to be sending out to anybody who's interested. So if you would like to get a free copy of this, just drop by the booth, leave your name card with the folks at the booth, and we will get a copy of this collected series of articles on neuroendocrine theory to you. When we're looking at cognitive enhancing substances, and there is a plethora of these substances out there, and of course the question is, well, gee, which one of these should I take? And I would say that's a good question, because there really is no set way to determine which cognitive enhancer is going to work in a particular situation. But what I usually do is I try to break this down as to what are the causes of cognitive impairment. They range from vascular, of course, atherosclerosis, metabolic changes, neurotransmitter alterations, many of which we've already talked about, endocrine changes, and accumulation of toxic products. Vascular, of course, is atherosclerosis, which impairs blood flow. Anytime blood flow to an organ is impaired, the functioning of that particular organ is, of course, also going to be impaired. Second is metabolic changes, and there are negative changes with age in glucose utilization and ATP production, as we talked about yesterday. Third are the neurotransmitter and neuropeptide alterations, and this includes the cascade of various neurotransmitters, the dopaminergic, catecholaminergic, serotoninergic, nicotininergic, and with the neuropeptides such as vasopressin and even perhaps TRH, as Dr. Pierre Paoli talked about yesterday. And finally, the endocrine. 4 was the endocrine, and 5 is the toxic accumulation of various substances. Dr. Kleinseck yesterday talked about the cross-linking, accelerating effects of aluminum accumulation in the brain. The Canadians have provided, I think, pretty convincing evidence that aluminum is one of the principal causes of Alzheimer's disease. Second is mercury. We are now becoming much more aware of the adverse effects of mercury accumulation in the brain, often due to iatrogenic causes from dental fillings, and finally lead. So this, considering that these are the causes then of impaired function, it gives us a number of various therapeutic approaches. First is vascular, and I will drop all the way to the bottom here because I think one of the best ways to improve blood flow to any organ is with chelation therapy. I'm a member of a group, there are 2 primary medical groups in the United States which use intravenous EDTA as a means of improving blood flow throughout the body. Of course, the standard approach to improving blood flow, whether it's through the carotid arteries or into the heart, is with bypass grafts, with endarterectomies, with stents. But these surgical and medical procedures only improve blood flow through fairly large vessels, but they really do absolutely nothing to improve blood flow in the microcirculation and down into the capillaries where the oxygen exchange takes place. So we use what I consider a much more sound approach. It's not just putting a Band-Aid on one particular organ. It's an entire system of improving circulation throughout the body. We use intravenous EDTA, which is a chelating agent which binds with toxic heavy metals, particularly aluminum, mercury, lead, and calcium, pulls it out of the system, and over time, series of infusions, anywhere from 10 to 30 infusions, will dramatically improve blood flow, and this has been well documented in a number of studies. That's the website for ACAM, the American College for Advancement in Medicine. There is another group called GLACAM, and they primarily use chelation for heavy metal toxicity. Other approaches to improving the blood flow into the cells in the brain is with ginkgo biloba. Ginkgo is a time-honored herb. It's been around for centuries. The standardized forms of ginkgo are now available. Our daily dose is 120 to 360 milligrams per day. Other benefits of ginkgo is that it will relieve angina pectoris and also is very good as an antihypertensive nutraceutical. One primary side effect with ginkgo is that it can result in impaired blood clotting. So if a patient is using other forms of blood thinners, platelet aggregation inhibitors, you may need to either titrate the dosage of ginkgo down, but I would recommend titrating the dose of the other blood thinners down. Vinpocetine is a very exciting substance. This is, and I say it's exciting because it's very useful in a number of conditions for which there really has been no other effective treatment. Vinpocetine is a periwinkle extract, and in clinical studies that have been made available by the pharmaceutical company in Hungary that developed it, they showed that it improves auditory acuity, visual acuity, and where I have found it to be most beneficial is in cases of labyrinthine disorders like labyrinthitis or Meniere's disease. This is the only substance that I have found to be effective in about 80% of the cases. It works rapidly and very effectively in doses anywhere from 10 to 40 milligrams a day, virtually non-toxic in higher doses, but I have not found doses in excess of 40 milligrams a day to be necessary. Hydergine is probably one of the oldest of the cognitive enhancing pharmaceuticals. This was popularized by Dirk Pearson and Sandy Shaw in their book, where they were taking, I think Sandy was taking up to 16 milligrams a day. Now that's really a very whopping dose. Most patients people do much better on lower doses. The standard dose in the United States is 3 milligrams a day, comes as sublingual or oral preparations. I've had patients that have taken up to 12 milligrams a day, but usually I think around 5 or 6 is optimal for most people. It's virtually non-toxic. Taking a little bit too much can cause some jitters and a little bit of nervousness. Hydergine was first developed as an antihypertensive by Sandoz and was promoted quite heavily, but it turned out that it was just a lousy antihypertensive medication. But sort of as a serendipitous finding, the people that were taking it were reporting that improvement in their cognitive abilities. So it was then promoted as a vasodilator, but they found out it really wasn't a very good vasodilator, that its actions are primarily on the brain. Acetyl L-carnitine is a cognitive enhancing substance that was developed in Italy. Again, listening to Dr. Brown this morning, I was intrigued again to see how the Italians really seem to lead the field in the development of cognitive enhancing substances. And there is some question as to whether the acetyl L-carnitine is necessary or whether someone can get exactly the same benefit with L-carnitine. This is one of those substances where the L-carnitine has been used primarily for its cardiovascular benefit, and the acetyl L-carnitine has been used primarily for its cognitive enhancing effects. Dr. Brian Leibovitz, who is, I think, one of the leading researchers in the world in carnitine, says that he thinks that the acetyl L-carnitine is just a more expensive version, is really not necessary, and you can get by with just the L-carnitine. The research is really not out there to substantiate that, but just for patients who are trying to save on expenses, I will sometimes just split the dose with them. Effective doses of acetyl L-carnitine range anywhere from 500 up to 3,000 milligrams per day, and I usually, again, go middle of the road to about 1,500. There are a number of substances that we consider just non-specific metabolic enhancers. What these do is to improve glucose uptake and oxygen utilization in the brain. One of these is centrophenoxine, a dietary supplement equivalent, and I think virtually everything I say about centrophenoxine, the same could be said about DMAE or dimethylaminoethanol. DMAE was used in the 70s. In fact, even though it is a natural substance, it was approved by the FDA for the use then in a condition known as minimal brain dysfunction. Well, minimal brain dysfunction today is known as ADD. But the FDA at that time was taking a broad sweep through the pharmaceutical industry, and for a number of old, tried and true drugs, they sort of wanted to clear up the field, it seemed. So they went to the drug companies and said, okay, we want you to repeat all the studies that you've done previously. and confirmed that this stuff works. And of course, by now, the patents had expired. It was a natural substance, so the pharmaceutical companies dropped it, but the dietary supplement companies did pick up DMAE, and I think it's probably one of the most effective, least expensive cognitive enhancing substances that there is. It's a mild cerebral stimulant. It increases the levels of acetylcholine in the brain. It's extremely safe. Excesses cause a little muscle tension, tightness in the neck, in the jaw, may cause a headache. It goes away rapidly with a reduction in dose. A very striking effect of both centrophenoxine and DMAE is its use as a lipofuscin inhibitor. Dr. Harmon mentioned that briefly in his talk. Lipofuscin is, of course, the age pigment that accumulates in the back of people's hands as they get older, but it's not just a cosmetic defect. It also accumulates in the brain, the heart, liver, kidneys. It is the most widely reported, regularly reported cellular aging change there is. And both centrophenoxine and DMAE both inhibit the formation of lipofuscin and accelerate its removal. And I know patients who have taken both DMAE and centrophenoxine, and over a period of about 6 months, they have watched the aging spots in the back of their hands disappear. But as I said, it's more than cosmetic, because that's a good marker of the reduction in lipofuscin accumulations in the brain and other organs as well. Centrophenoxine and DMAE enhance glucose metabolism, increase membrane fluidity, and has been shown to extend the lifespan of mice. We showed the slide yesterday with DMAE, and this was a similar experiment done by the same researcher with centrophenoxine in mice, and he showed again that both DMAE and centrophenoxine very similarly extend the maximum lifespan of experimental animals. These were studies that were done back in the mid-70s, and it's amazing that no one has ever replicated these lifespan studies since. Other metabolic enhancers that we can consider, again, acetyl L-carnitine, which normalizes mitochondrial cardiolipin concentrations, and I showed that yesterday, where it literally rejuvenates the levels of cardiolipin in the mitochondrial membranes to those of youthful animals. Again, it doses anywhere from 500 to 3,000 milligrams per day. Talked about hydrogen. Some other effects that it has is that it increases cyclic AMP and ATP. It actually does increase ATP production. It's a dopaminergic and serotonergic agonist. And very strikingly, Dr. Brown correctly stated this morning, you need to start early in a cognitive enhancing preventive program, because once the brain cells are lost, there's often very little we can do. But hydrogen is one substance that has been actually demonstrated to increase neurite growth factor and to increase synaptic density of the dendrites. So hydrogen is one substance that clearly will reverse to some degree many of the degenerative changes in the brain. Already talked about vinpocetine. Other non-specific metabolic enhancers, phosphatidylserine. Phosphatidylserine is a vital constituent of cellular membranes. Again, the Italians did the studies in Alzheimer's disease and in improving cognitive performance in normal individuals using doses of 100 to 300 milligrams per day. Now, phosphatidylserine was originally actually a brain-derived product. It has since been derived from lecithin. In fact, the animal-derived product is no longer available, so all the phosphatidylserine products that are available are safe, and no concern about the BSE. Idebenone is a really interesting addition to the cognitive enhancing arena. It is an analog, in fact, it's a fraction of the CoQ10 molecule, but it seems to have many of the same effects of CoQ10. CoQ10 has not been widely studied for its cognitive enhancing effects, and that's primarily where idebenone has been tested, effective in doses ranging from 45 to 90 milligrams per day, particularly effective in stroke recovery. Probably the largest class overall of cognitive enhancers are the nootropics. Piracetam is the prototype This is molecularly very similar to pyroglutamic acid, a naturally occurring substance. There are other nootropic analogs, aniracetam, pramiracetam. I usually stay with the original. I know Phil has his ideas on that, and he likes some of the other newer analogs of paracetam, effective in doses anywhere from 1,200 to 3,600 milligrams per day. The mechanisms of the nootropics are not really clear. We believe that they increase the levels of acetylcholine in the brain, and they have the unique characteristic, it seems, of connecting the left and the right halves of the brain. So it makes left brain people a little more right-brained and right-brained folks a little more left-brained. So we wind up using all of our brains with these substances. I always take this every time I fly. When we fly, the aircraft are pressurized to 8,000 feet altitude. Well, in the military, we put our pilots on 100% oxygen at 10,000 feet. So when you're walking around the airplane, kind of stretching your legs, and you see everybody zonked out, it's not because they're so tired or fatigued. I believe it's because they're hypoxic. And that's why it's so easy to fall asleep on an airplane, because your brain is really starved of oxygen. Paracetam has been used in high-altitude sickness to prevent high-altitude sickness. I remember once I was attending a meeting, in fact, with John Morgenthaler in Vail, Colorado, and he just had this pounding headache. We weren't used to that kind of altitude, us sea-level folks, and a run down the hall to the elevator was leaving us breathless, even though we're trying to keep ourselves in pretty good condition. And John found, just again serendipitously, the tremendous energizing effects of paracetam. It relieved his headache, reduced his oxygen hunger, so to speak, and I've since then have used it on many patients because it does reduce the brain's requirement for oxygen. Another approach is to replace or to try to restore the normal balance of neurotransmitters and neuropeptides. We can replace them altogether in some cases. We can use precursors and cofactors. We can use enzyme inhibitors like MAO inhibitors, cholinesterase inhibitors, receptor agonists, some of which I talked about yesterday, and even the reuptake inhibitors. With regard to replacement, I discussed vasopressin briefly yesterday. Vasopressin is probably one of the best ways to improve short-term memory. Been tested in patients with Alzheimer's disease. It's great for students who are studying late at night. The cobwebs start creeping in. A couple of snorts of vasopressin clears the cobwebs and improves the recall the next day of the material that has been studied that night. Although it does not cause people to go to sleep, in fact, it is actually an alerting substance. You become more alert when you take it. It does enhance sleep, and as I mentioned, it increases slow wave sleep, which is the period of sleep when growth hormone is produced. It reduces urine production. I think one cause of sleep impairment in men, particularly with prostate problems, is that they helps them to sleep throughout the night. They don't have to get up in the middle of the night to relieve themselves. That in itself improves cognitive performance if we can get enough sleep. As I mentioned, it does literally rejuvenate intracellular water balance back to that of more youthful animals, and it reduces the mortality of old animals. So I think that vasopressin is probably one of the unsung and dramatically underappreciated cognitive enhancing anti-aging substances. We've already mentioned centrophenoxine and DMAE. Choline is widely available and has long been used as a means of increasing levels of acetylcholine in the brain, also in combination with vitamins B6, B12, folic acid, ATP, CoQ10, and to this I would also, after listening to Dr. Brown today, add SAMe. Other precursors that can be used are tyrosine and phenylalanine, which are converted, of course, into L-DOPA and the catecholamines. Can balance the serotonergic neurotransmitters with tryptophan when it's available, and with 5-HTP. Tryptophan, of course, was taken off the market about 2 months before Prozac was introduced, allegedly due to eosinophilia myalgia syndrome, which was caused by a contaminated batch of tryptophan that was manufactured in Japan. This was recognized by the CDC. The FDA said, no, off the market. So tryptophan is not available as a dietary supplement. However, it is available in feed stores. You can buy it by the bucket in a feed store because it is used in animals, and it's also still used in IV feedings and in baby food. So it's the only people that it's dangerous for is people who are not getting hyperalimentation or consuming baby food or for animals. 5-HTP is one further step in the conversion from tryptophan to serotonin. Tryptophan is effective in doses anywhere from 500 to 2,000 milligrams, generally taken at bedtime as a sleep inducer. 5-HTP can be taken in doses anywhere from 50 to 300 milligrams. It has been used in doses up to 900 milligrams daily in weight loss studies. But once you get above 300 milligrams a day, there is some gastrointestinal problems with that, and so you can kind of let your GI tract be your guide. We talked also about Deprenyl, developed by Professor Knoll. Deprenyl is one of the most widely tested anti-aging drugs based on Professor Knoll's work. It's also an aphrodisiac, primarily used in Parkinson's disease. And Professor Knoll, although it was originally developed as a monoamine oxidase B inhibitor, that in his experience he believes it actually is a dopaminergic receptor sensitizer. Now, the use of Deprenyl, well, actually not the use, but the sale of Deprenyl has been found to be hazardous to one individual at least, and I think this was the only individual that's ever really been harmed by Deprenyl, and that is a fellow named Jay Kimball. Mr. Kimball was the owner of Discovery Experimental in Florida. They were the manufacturer of one form of Deprenyl that was being sold as a dietary supplement. Mr. Kimball is now doing 13 years in federal prison. He was charged with 5 counts of misbranding. Misbranding is a misdemeanor. It's like getting a speeding ticket. The FDA took those 5 counts of misbranding, created this fictional international money laundering conspiracy to defraud the FDA. They claimed that he was endangering the public welfare by making this product available, and tried to send him away for 40 years, but only succeeded in sending this 61-year-old father of a 10-year-old son to federal prison for 13 years, where he is today. I testified at his trial. The judge challenged the prosecution that during the 10 years that they were investigating Mr. Kimball, there's not one person who ever complained, not one person who had a problem with Deprenyl, and in fact it was gone through 9 grand juries before they finally found a 10th grand jury in 10 years to indict this guy who is now in prison. So one of the tragedies of making this wonderful substance available. Huperzine A is another recently introduced cognitive enhancer. This is a cholinesterase inhibitor, been tested widely in China and more recently in the United States, effective in Alzheimer's disease in doses of up to 200 micrograms per day. It's also been used as a cognitive enhancer in normal people with good effect. TRH, and I was hoping to twist Dr. Pierpaoli's arm to give us even more information about TRH. I think this is going to be one of the most exciting anti-aging substances, and I'm hoping he will take his unpublished papers, which he's sitting on, and get them out for the rest of us to know about. In the endocrine arena, melatonin replacement. Melatonin was, there are studies out there that show that melatonin actually impairs cognitive performance. However, this was in studies where they gave the melatonin during the day, and several hours later, put people through cognitive evaluating tests. So of course, as these people are drifting off to sleep, their cognitive performance was obviously impaired. There are subsequent studies which have used it appropriately, making sure people got adequate sleep, and in tests given the following day, melatonin itself was proved to be a cognitive enhancing substance, and I think we've just heard from Professor Anisimov about the benefits of both epithalamin and epithalon. Pregnenolone is known as a neuroactive steroid. It's one of the hormones that has been demonstrated to be effective in Alzheimer's disease and in normal people. I think part of its benefit in Alzheimer's disease may be due to its anti-inflammatory properties. Pregnenolone should be taken in doses anywhere from 10 to 100 milligrams a day, although it's virtually non-toxic. In studies that were done by Dr. Roberts, he used doses up to 600 milligrams per day for periods as long as 6 months with absolutely no adverse effects. DHEA has also been demonstrated to have cognitive enhancing effects, and one of the most common manifestations of hypothyroidism and subclinical hypothyroidism is impaired cognitive performance. Finally, with regard to the toxics, one thing, of course, is to eliminate the toxic source, whether it's mercury amalgams in the teeth, whether it's aluminum and other toxins in the drinking water. DMSA is available both as a drug and a dietary supplement. It's available as a source of succinic acid. This is the substance that is recommended for use preferentially in mercury toxicity. To conclude, there is no silver bullet with regard to improving cognitive performance. There's a wide array of substances out there to choose from. I usually recommend that people try one and go from one to the other until they find one that works, because it depends, again, on what is causing the impairment. A pharmacist friend of mine, when the book first came out, he just went running through the list and tried one cognitive enhancing nutrient or drug after another until he finally hit Dilantin, and he said when he took Dilantin, it was like the lights came on. He was able to focus and concentrate, where before he was having problems staying focused. We find that combination approach is most effective, that these substances actually are synergistic. They can safely be used in combinations, and I always recommend to start with the lowest effective recommended dose and increase it until an effect is noticed up to the maximum effective dose, and then to add another substance. And once a person gets experience in taking these things, they know how one thing affects them, and so just through trial and error is really the best way. Now, there is a system out there. I think the website is cognitivecare.com or thinkfast.com. These are computerized assessment techniques of cognitive performance, and they have done studies showing both before and after using their evaluation system the beneficial effects of both ginkgo and vinpocetine on processing speed and memory. And finally, the Hippocratic Oath, do no harm, and that's why I generally have people avoid things like Tacrin, which is probably the most widely used drug for Alzheimer's disease, but which prolonged use has fairly high incidence of hepatotoxicity, whereas the substances that I've discussed today are virtually without toxicity, extremely safe, and been demonstrated to be clinically effective in a number of tests. Thank you.